So welcome again. Life with Nurse Carol. My name is Motes Caroline. We are going to look at our second part of the endocrine system. And well, here we are going to be covering the anti-diuretic hormone, ADH. Looking at our anti-diuretic hormone, also known as the vasopressin, we need to know what exactly happens in the body for the anti-diuretic hormone to be secreted. So the osmoreceptors in the posterior hypothalamus regulate the amount of ADH released by the pituitary gland in response to the changes in the osmotic pressure of the plasma. So the osmotic pressure is related to the concentration of blood, and we understand that the less fluid in the body, the higher the osmotic pressure that will be of plasma. So what does this tell us? We need to note something, that the pituitary gland is located in the brain between the eyeballs, and therefore a patient who has had a craniotomy, head injury or sinus surgery should be monitored for any effects of pituitary gland damage which could affect the ADH production. So you find that after such surgery, someone is passing out lots of urine. So before you start investigating for kidney failure, kidney something, you need to first know your anatomy, where the pituitary gland is located in relation to the surgery that was done. So how does the ADH function in the body? So the main action of ADH is in the kidneys and is to regulate the volume and the osmolarity of the urine. Specifically, it acts in the distal convoluted tubules and the collecting ducts, causing them to reabsorb water and the sodium ions. So what is our memory lane for antidiuretic hormone? One, you should know that anti also means opposition. Diuretic would mean passing out of urine. So if I have an anti-diuretic hormone, it's like I have an opposing urination hormone. I'm opposing urination. So if I don't have enough ADH, if I don't have enough hormone that opposes urination, I'll get a disease or a syndrome called diabetes insipidus, and this is when I pass out excessive water through the kidneys. However, if I have too much ADH, it means I'm building up too much opposition against urination. So here we get a syndrome of inappropriate antidiuretic hormone, and it will clinically present by excessively retaining a lot of water by the kidneys. So let's look at our first condition, diabetes insipidus. I know you've heard the word diabetes mellitus, diabetes insipidus. They have some similarities. However, the difference between this and the other is that here we are not passing out any glucose in urine. So what does this look like? There is not enough ADH in the body, hence the kidneys produce large amounts of dilute urine. Like I said, if we don't have enough antidiuretic hormone, it means we are not able to oppose urination. It means we are passing out a lot of urine compared to the normal person. So this in turn leads to fluid volume deficit, causing hypotension and shock. So how does this patient clinically present? They'll excessively want to drink water due to the thirst, and this is also termed as polydipsia. Then they'll excessively pass out urine, also known as polyuria. They'll present with dehydration because they're passing out literally every fluid that they have in their body. They have disrupted sleep patterns because all the time they have to wake up and use their loo. Hypotension, and then tachycardia, because if the fluid in the body is reduced, the vascular system is compromised. So the heart is working as hard so that it can pump the necessary oxygen and nutrients to the extremities. So you end up with increased heart rate. How do the lab values present in diabetes insipidus? In a situation where we are passing out a lot of urine, the urine will be dilute first of all. However, since the urine is dilute, it will leave our blood more concentrated. So you should understand that in diabetes insipidus, we are passing out a lot of urine. It means the urine specific gravity will be reduced. It means the water content is increased, and hence the decreased sodium concentration in relation to the water content passed out. For the blood, it will remain concentrated because we are literally getting every fluid from the body to pass it out as urine. So there will be increased sodium concentration, also known as hypovolemic hypernatremia. So the sodium concentration may not be so much affected, but because the volume that is supposed to maintain a balance is being passed out, we end up with hypovolemic, which means reduced volume. However, it is more concentrated with sodium than usual, which is the hypernatremia. The serum osmolarity will be highly increased, and also the serum hematocrit will be greater than normal. So how do we manage people who are passing out urine excessively, people with diabetes insipidus? The medical management one is to replace that hormone or something similar to that hormone, and in this case we have the intravenous vasopressin. So this is given to act as ADH and hence retaining more water than it should have been passed. So also, since they are passing out a lot of water, we need to replace the fluids so that these people can get into balance. The nursing considerations: people are very high at risk of dehydration and shock, so you need to watch closely for input and output. You need to watch for signs of dehydration and you need to watch for signs of shock, and hence manage accordingly. Second, we have the syndrome of inappropriate ADH. So in this case, where we are opposing so much the excretion of urine or the excretion of water, we'll have so much of it being retained in the body. So in this case, the body is producing too much ADH, causing the kidneys to retain a lot of water. So how does this patient present? They will have decreased urine output because we are opposing urination. And since we are opposing it, there is so much water that's remaining in our system. And this will increase the volume of blood. So you will have jugular vein distension because the volume is highly increased. We will have edema. The fluids will start seeping into the cells and in between the cells. We will have weight gain because of the fluid overload. We will have hypertension, we will have nausea and vomiting, we will have anorexia due to ascites, and then we will have dilutional hyponatremia. While in diabetes insipidus we had hypernatremia, hypovolemic hypernatremia. Here we will have dilutional hyponatremia because while the sodium concentration may remain the same in blood, the water being retained dilutes it. So we'll have dilutional hyponatremia. So we are opposing urination, meaning there is less that's passing out. It would mean that our urine that's getting out is more concentrated. And since there is more water being retained in the body, it means there is so much dilution of our blood. So urine will be concentrated, hence increased urine specific gravity. It will have increased urine sodium, and then it will have decreased water content. For the blood side, we'll have decreased serum sodium because of that dilutional hyponatremia. We'll have decreased serum osmolarity because of the retention of water, hence the dilutional hematocrit concentration lower than normal. So how do we manage a condition where we are highly opposing, where we have too much ADH, medical management. In all cases of syndrome of inappropriate ADH, the first step is to limit your fluid intake. Your body is already overloaded with fluids, so the best thing you can do for it is to limit your fluid intake. Second, give drugs that will help us expel the excessive fluid, like diuretics. Lasix usually is used in conjunction with normal saline to replenish the sodium excreted with the diuresis. So you know that Lasix is a diuretic, so it will excrete everything, but at the same time, remember we had dilutional hyponatremia. So we give Lasix in conjunction with the normal saline contributing to our sodium, to improve our sodium levels, but the Lasix helping us to remove the excess fluid. Also, we give a drug called demeclocycline. This is also known as a tetracycline antibiotic. However, it has other effects that would help us in this syndrome. It works by reducing the responsiveness of the collecting tubules to the antidiuretic hormone. So instead of the antidiuretic hormone having very much effect like it should have, because of the reduced sensitivity to its action, there will be less water being retained because its action is not being enabled. This is something that you should note. If you have severe symptoms of hyponatremia, such as confusion and seizures, this is a medical emergency. So as you're having a patient with these syndromes, you need to do your electrolyte analysis. You need to analyze closely and monitor this patient closely. You need to consider this patient that at risk for seizures and put seizure precautions in place. So some of the nursing considerations is closely monitor your sodium. Also consider seizure precautions, monitor input and output, hence facilitating your fluid restrictions. So we've covered so much here. It's been brief, but it has all that you need to pass your exams and also to manage your patient. Thanks for listening. Continue watching Life with Nurse Carol. Next, we'll be covering something else about the endocrine system. So stick with us. Life with Nurse Carol. Love you all. Bye-bye.